Let's introduce Dr. Gary Wenk as our first speaker. He's going to be talking about the science behind medical marijuana. Dr. Wenk is a professor of psychology and neurosciences at Ohio State. He also has a history in the Department of Psychology and Pathology at Johns Hopkins before Ohio State. He's currently the director of the undergraduate neurosciences program and serves on the governor's medical marijuana advisory committee. And perhaps most importantly, he was a guest of Dr. Oz's 2 years ago. So with that distinguished introduction, Dr. Wenk, please talk to us about the science.
Thank you, everyone, for coming out on Wednesday night. I appreciate that. And also, I want you to know that I'm a rat guy. Those are my patients. So all the stuff that you're going to hear about is preclinical research results to help you understand what marijuana does. And you won't know why, because we cannot give it to humans yet. There is no clinical data. What we have is anecdote for the most part. But what I want to make sure you understand is what we do understand about what marijuana might be useful for one day. So the thing you need to understand about marijuana, and you've got a sense of this already, is that it's a very complicated topic. The molecule itself is one of thousands that live in the plant. And THC, which is the one we focus on most often, binds to one of 4 or 5 receptors in the brain. I'm not going to go through all of those. We understand where the receptors are. They tend to be everywhere. That makes it really easy, right? So when your patient asks you, what's this going to do to me, the answer is lots of things, and I can't explain all of them. That's where we stand right now. So essentially, there are 4 known receptors. There are probably more. As we pursue this further, we'll learn more about them, but essentially the simplest thing to believe is that it's everywhere. How you experience marijuana is determined by what's in the plant. This is the same thing you could say about whatever is in the little white pill that you get at CVS will determine what the experience of that drug would be. Well, this is just a small percentage of the things that are in the plant. And not only is it a complicated blend of compounds that produces this aggregate effect in the brain, but in fact, the contents of the plant change depending upon who you are and how you're using it. So, for example, if it lays out in the air and dries out because you've been storing it, in the refrigerator or something, you get where the red arrows are pointing. If you burn it versus eating it, you get a different collection where you can see here the brown arrows. And if you the gray arrows, if you metabolize it through your urine, through the liver, you get a different set of compounds. So how are you using the drug? That influences what it's going to do to you. Now, the ones that we care most about, that I'll focus on, because this is what you hear most about if your patients are interested in using it, and that's THC, which is buried here, and CBD, which is up here. All right? THC is the primary cannabinoid. It is the most abundant one. For every 100 molecules of THC, there's about 50 of CBD. The others are fairly low concentration. But do they contribute to the effect of the drug? Absolutely yes. So many of these compounds in here act on the body and brain, but they're in very low quantities, and whether they act upon you depends upon what you're using. Are you using marijuana? Are you using an oil? Are you eating hundreds of milligrams of it? So what you experience depends on these blend of compounds and what their ratio is. Where the drugs act is well known, but that knowledge doesn't really help very much because there are 2 known receptors, CB1, CB2. These are the CB1s. They're everywhere in the brain. It's the most common G protein linked system we have in the brain. This makes interpreting what the drug is going to do especially difficult. So if you look at it, you can find that it's in thalamus, it's in the amygdala, it's in visual cortex, it's in primary auditory cortex, it's in places that will affect how people hear and see, think and feel, and affect their moods. So it's everywhere. But let me point out something to you that you're going to hear. People are going to tell you, well, this is a very safe molecule. No one's ever died on marijuana, but people have died with alcohol. That's a true statement. This is why. We don't find cannabinoid receptors in brainstem. So it doesn't seem to be able to kill people or animals because it isn't able to act on vegetative centers. So it affects higher cortical function. CB1 receptors are in the brain mostly, they're also in the body. CB2 receptors are mostly in the body, they're in the brain. So you can see yourself where you find them in the liver, the pancreas, the gonads, and scattered through the intestines. They are everywhere. They are on immune cells. So if someone asks, what's this going to do to me? The answer is many, many things. And it isn't always obvious, what the answer might be for each individual. Now, in our bodies, those receptors are stimulated by our own neurotransmitters. You heard this when you were in medical school, but our brains make quite a variety of psychoactive drugs that we've been discovering over the years. These are the two most common. There are 7 of them that are known. So your brain makes a whole family of cannabinoids. Your brain makes it, these two, out of fat. This is just a string of hydrocarbons. Anandamide was found first. The most common one is 2-AG. Essentially, when you eat a lot of fat, one of the things your brain does is thank you for the fat. Fat, salt, sugar are things our brains really like. One of the most important things to understand about the brain is that our brain always wants us to do things our body would prefer we didn't do. This is one of them. So anandamide is also found in cocoa powder. So chocolate contains anandamide, but the levels are pretty low. So anandamide itself, shown here when it folds up, looks like this, and this is what THC looks like. Another principle you learned about many years ago is that in order for a molecule to be psychoactive, it must get in the brain at an adequate concentration. This one can, and it must look like a transmitter. Here is the transmitter, and here is the exogenous drug. So if a drug doesn't look like a transmitter, we call it a nutrient. It doesn't do anything to us, so it's not particularly interesting. These look like transmitters. Okay, so what do people use marijuana for? To target these receptors to mimic anandamide. And essentially, this is an epidemiological study of what people choose to use it for, and this is simply the number of times people don't use other medications. So what I want to do is just break down just a bit to show you how we can understand this component. So when we look at pain, pain is the most common reason people turn to marijuana. When given the opportunity to use it, say in Colorado or California, they turn to marijuana. We know that marijuana acts on glutamate to prevent its release, and TRPV1s, which are one of the receptors I mentioned. All right, there's no test, so don't worry, okay? So if you look at this, then this explains the JAMA Internal Medicine article from a couple years ago that said in Colorado, after recreational marijuana was approved, heroin overdoses went down 25% because people are turning to it. Does it work for pain? Yes, not as good as morphine, but it is effective. And you can just keep dosing yourself, which is you cannot do with morphine. Anxiety, this is where CBD comes in. CBD is an interesting molecule that you're going to hear a lot about. People sell CBD concentrations in oils. CBD is an inert compound. It cannot produce a psychoactive high for the simple reason that CBD lacks the ability to stimulate cannabinoid receptors. It's inert. But it is psychoactive. It is able to stimulate 5-HT1As. You may be familiar with another drug that stimulates 5-HT1As, and that's Buspar, a common anti-anxiety medication. So CBD is able to reproduce what this other drug does, and people choose to use it because of that phenomenon. They use it to reduce their nausea because of what it does to acetylcholine. CBD may have a future in the treatment of psychosis. It's not an ideal drug, but as an adjunct, it may help. So we're beginning to understand how the drugs benefit us. And finally, seizures. This is one that's become an absolute urban myth, that CBD is treating seizures. Absolutely not true. The American Epilepsy Association has come out strongly and said it doesn't work. The only children who benefit from CBD in Colorado are the ones whose parents moved into Colorado. If you're born in Colorado, it doesn't help you. Guess what? Placebo effect works sometimes. So CBD is useless. However, THC and some of the other compounds that are in that mess of molecules are capable of blocking sodium and calcium channels and reducing glutamate release. Does it work for seizures? It could, but it's not CBD. So it could work, it's just not that molecule. So moving on then, how does it work for pain? CBD stimulation by marijuana induces the release of endogenous opiates down here in your spinal column. So is CBD useful for pain? Possibly. The data we have from animals that says for neuropathic pain related to these other things, and migraines in particular, which is not approved in the state of Ohio yet. Now, is it good? Well, multiple studies say that it is significant, but not very dramatic in terms if you compare it to morphine or heroin or something like that. It is pain relieving, it is analgesic, but it's not, really quite impressive. Now, I mentioned migraines. Any of you who are thinking of prescribing some of the anti-migraine drugs that are blocking CGRP, this is why they work. In that synapse, they release CGRP. Cannabinoids prevent the release of CGRP. So you can give them an antibody, or you can give them marijuana. It's going to relieve migraine pain. But it's not approved in Ohio yet for it. So what does it do then? I want to show you some animal research. Big cartoon here. Essentially, this is where the cannabinoids act. They act on nerve terminals. They act postsynaptically, presynaptically, and glia, but follow the two lines of arrows. Cannabinoids reduce inflammation. That is contributing to the reduction in pain. They also prevent cell death due to glutamate. If someone had a severe head injury, probably the best thing they could do from animal research is to smoke marijuana heavily for a couple of weeks, because it would prevent inflammation, prevent necrosis, and prevent apoptosis of cells from dying. So it would rescue neurons in the presence of inflammation and injury. Let me show you a study from an animal. This is what happens. This is actually a section of hippocampus. This is a hippocampus that is inflamed. All these little blue cells are activated microglia. And this is a hippocampus on 3 weeks of 1 puff a day of marijuana. The reason I went to 1 puff a day is, or this is an equivalent of 1 puff a day, is because the blogs for people with multiple sclerosis said that 1 puff a day relieves some of their pain symptoms. Marijuana at just 1 puff a day, equivalent for a 70 kilogram human, was enough to wipe out inflammation in the brain due to the inflammation I generated, or due to the inflammation that occurs with natural aging. So it has a future there, I think. In addition, whenever you wipe out inflammation in the brain, you restart neurogenesis. This is neurogenesis, these green cells in a young brain. This is a neurogenesis in my brain, an old brain, none of that going on. This is after just 3 weeks of 1 puff a day. We restart neurogenesis. And when I look at spatial memory in a rat, young rat, here's an old rat, dumb, and here's an old rat on marijuana, smart. This is amazing. You're not going to be able to convince anyone that you can turn an old person into a young person, but this is what we see in our animals. I don't know what we're going to find in humans because we haven't done these studies, all right? So what we think happens then is that by acting at glutamate, by preventing the release of glutamate, it reduces pain, it reduces inflammation, and so this is what I think is the future, that it will be useful from preclinical studies in rats, all right, for treating pain related to all these things. It'll probably help. It may prevent these things. The epidemiological evidence says that people who smoked marijuana in the 1960s and 70s, who are today likely to get Alzheimer's or Parkinson's, are not getting it as often as they should. So if you were lucky and smart enough to have smoked dope in college, right? So my advice is that if you're after age 50, 1 puff a day, all right? That's what we do to the rats. It will wipe out brain inflammation and restart neurogenesis. But that's not the future. So 2 slides. I want to show you what's the actual future. When marijuana is recreational available here, this is where what's really going to happen. When you were in medical school, we lied to you about how Tylenol worked because it was a good lie and made sense. What we now understand is that Tylenol actually forms a cannabinoid in your brain. Here's an antibiotic. This is what Tylenol becomes. Tylenol is a pre-cannabinoid. It shouldn't even be legal, but it is. What it does is it does something really interesting. It forms a pre-cannabinoid, a cannabinoid-like compound that blocks the inactivation, the reuptake of cannabinoids. So, cannabinoid reuptake inhibitors, these are the things I'm testing now from drug companies in Europe who know that Americans are going to be a great market for marijuana. So this is inflammation in an old brain. This is after 3 weeks of 1 puff a day. It looks good, not bad. This is with a UCM707, that molecule, which is invented by Sanofi Aventis. It's even better. So the future then is not medical marijuana found in the plant. It's not things found in the plant. These are things that people can patent. So it appears likely that selectively augmenting our own brain's endogenous cannabinoid system by drugs that don't make us high necessarily, those will be beneficial for pain and inflammation. So this is what will likely happen. This needs to be handled. You take UCM707, nothing happens. And then later today you have a happy thought. And you go, wow, that is really a happy thought. And then what happens is it gets happier and happier and higher until finally every single cannabinoid terminal in your brain is active and enhanced, and you become as high as you are capable of becoming for a few hours until they figure out how to turn the drug off. They're working on that part, but essentially you will just simply be high when you want to be high. You know, that's what's going on. So the point being, which would your elderly patients prefer to do? Smoke a joint or take a little white pill? This is what the drug companies are assuming is going to happen in the U.S. because of what we've learned from animal studies. All right, did I make it 15?
Well, that was a great backdrop to our second speaker, which is Dr. Jerry Mitchell, who's going to talk to us about the uses and in particular pay attention to the clinical studies. Now, Dr. Mitchell comes from Wake Forest through University of North Carolina and eventually to University of Pittsburgh. He's board certified in internal medicine, hematology, medical oncology, hospice and palliative care, and was appointed in 2016 as well by the governor to serve on the Medical Marijuana Advisory Council and currently serves in that role. He also has his MBA, so we'll hopefully understand maybe some of the aspects on the business side of this from your talk. But let's introduce Dr. Jerry Mitchell. Thank you.
Thank you guys for having me. Now, the problem is I have to talk after Dr. Wenk, and he's so smart, I am going to look like a dummy, but I'll do my best. So what I've done is I've broken down the talk into two sections. The first section is really an overview of the data that we have in essentially the oncology and palliative care setting, because that's my expertise. And then I wanted to spend a few minutes on the current regulatory environment in Ohio so that everybody knows where we stand, if you are a physician, what you need to do if you want to be a recommender. So I've got a few minutes on that as well. I also think it's important to know why the state of clinical research is where it is in the United States, and I'm going to take a little history lesson. So in 1937, that was the first time the federal government regulated marijuana, and all it did was tax it. It did not ban it. It did not say you couldn't use it. It just put a tax on it, and then it left it to the states if they wanted to ban the product. But they said you got to tax it if you're going to let the states use it. So the states started banning it. Then in 1970, the Controlled Substance Act passed, and that's when marijuana got federally banned. It essentially, at that point in time, became a Schedule I drug. So Schedule I drugs have no known medical use, and that's how it currently stands. In 2016, the Obama administration thought about making it off the Schedule I, but they elected not to. So as of right now, it's a Schedule I drug. You can only get plant material from one institution, the University of Mississippi, and that got its charter to produce this back in 1970, so with this. So if you want to do medical marijuana research on the plant material, you have to petition the government, and then the government has to say, okay, your research seems all right, and then you have to get your plant material from the University of Mississippi, and they grow what they want to grow. So if you want a particular strain and you want to look at something, well, you may not be able to do it legally, because you have to get it from the University of Mississippi. In 2015, the NIH did spend $111 million on medical marijuana research. However, the bulk of that was basic science, and I really hope you got some of that money, Dr. Wenk. You did not? Okay. Well, we should have. The first thing I want to talk about is marijuana in neoplasia. And I think this is a really important slide because one of the things you hear in lore is that, oh, marijuana treats cancer. That is common. You will see that everywhere. There have been some cell-level studies showing an inhibition of the growth of cells with certain cannabinoids. But that's it. There is no evidence or data that this does anything to treat cancer. And that's a really important message. So, in neoplasia, absolutely nothing. So if someone says, well, I want to take this to treat my breast cancer, it is not going to treat their breast cancer. So, however, as Dr. Wenk talked about, there is a lot of evidence that it can be effective in chronic pain. And actually, you referenced an article that I'm going to reference, which is the Bradford study. And I'll get that in a second. But the most common medical reason in Colorado, like Dr. Wenk said, is for chronic pain. 85 to 95% of the patients that are using medical marijuana are using it for their chronic pain. Many of the patients are substituting marijuana for the opiates that they had been on. So the Bradford study looked at Medicare Part D spending. And what that demonstrated was that in the states that had medical marijuana laws, spending on Medicare Part D drugs for what they were taking to treat their condition, the spending went down by $165 million, and almost all of it was in opioid reduction spending. So, I mean, that's really powerful about what patients are doing. They are using medical marijuana to treat their chronic pain, and they are ditching opioids in favor of it. A follow-up study was done in the Medicaid population by the same group, and that was published in 2017, and that demonstrated very similar findings, which is you get a reduction in prescription drug spending in states that have made marijuana legal. There was a further study that showed that there was a 64% reduction in opioid use for chronic pain in states that had medical marijuana. So the evidence is pretty clear across the board that in states that are making medical marijuana available, you're getting a reduction in opioid use. I do want to talk about the clinical data in chronic pain. The best data out there actually is a meta-analysis published by Wenk. She looked at a whole host of conditions, but specifically did a meta-analysis in chronic pain. There were 28 studies. 22 of the studies in the meta-analysis were with plant material, 5 were synthetic. And what it showed in the meta-analysis that there was a statistically significant reduction in chronic pain compared to placebo, and that it was equivalent to what other folks, what they were getting with their other products. So in this meta-analysis, at least, there's pretty good clinical data that it is effective in chronic pain. The majority of the pain that was looked at was cancer-related pain and neuropathic pain. The National Academy of Sciences in 2017 looked in detail at the health effects of medical marijuana. It's 400 pages, very detailed, great references. And they concluded, based on the evidence that they looked at, that there was substantial evidence that cannabis is an effective treatment for chronic pain. Here are the limitations. You don't know what's in the plant. You don't know how it was handled. You don't know where their supply was. It is a real challenge to interpret a lot of these clinical studies. What it reminds me of is in 2004, there was a study of a product called PC-Spez. I don't know if you guys remember PC-Spez, but it was used for prostate cancer. And it was really popular. And the NCI actually did a great trial. They took PC-Spez and they gave it to men who had hormone-refractory prostate cancer. They stopped the trial early. And the reason they stopped the trial early is they were comparing it to DES. They stopped the trial early because they did an NMR on every lot of the PC-Spez they got. And they found that it was all contaminated. So that's the problem you get with these studies. You're not going to have a pure study because you're not going to have a pure product. And it's a challenge, and it's a challenge when you're trying to make recommendations to your patients. So that was the limitation. Very little known. Nausea and vomiting. Most of the studies in nausea and vomiting are old. And the majority of the studies actually involve a commercially available product called Marinol. When people started using marijuana for nausea and vomiting, we didn't have very many treatments for it. It was a huge breakthrough when the 5-HT3s came through and Dansitron came through. But that's been years ago. Those came out in the late 80s. We have lots of great medicines to treat nausea and vomiting. So there's some older data that suggests it works, but I would argue that what we have available for chemo-induced nausea and vomiting is much better than what you're going to get out of medical marijuana. But there is data. Meta-analysis did demonstrate that it's better than placebo. And so if you have a patient that cannot tolerate the standard treatments, the dancetrons, the topazines, it's worth a shot. because everybody is a little different. Some people can't tolerate what you're giving them, and there is some clinical evidence that it's got some efficacy. So, marijuana, other palliative roles, HIV, AIDS, weight loss. This actually has been looked at. The data is very poor. It looks that you can gain about 0.1 kilograms using it. So is that effective? Is that not effective? 0.1 kilograms, not very much. But if your patient likes it and it's helping them and they're getting a benefit from it, I can make a very good argument, why not? Cancer cachexia, same. Very little data that it helps cancer cachexia. If it does not help as much as Megace, and it has been compared to Megace, but I would argue that is a very low bar because Megace also doesn't work very well. So, you know, it's kind of like, well, I can run a 40-yard dash in 20 seconds, but I can run it in 21 seconds. Yeah, it's not that helpful. There actually is some moderate evidence for short-term sleep disturbance improvement. The trial that looked at this, it was very short-term, didn't look at it long-term, and so I think it really is unclear whether this is something that might be effective for someone who wants it more than a week. There is no clinical evidence, none, that this is effective in anxiety and depression. And I think a lot of the reason that we don't have any evidence here is because of the issues of being able to get good material, do well-done trials, and to actually compare it against a product that's already approved. As Dr. Wenk talked about, there may be a role for CBD, but I think that we're going to have to get a better regulatory environment before we can actually study it. So if you have patients that say, well, I need medical marijuana for my anxiety and my depression, again, we do have medicines that have randomized clinical trials that show they work. I don't think that this is something that right now is ready for prime time in terms of clinical evidence. All right, so now I'm going to talk a little bit about the regulatory side of things. So as you guys know, in 2016, the state of Ohio did pass a medical marijuana bill. The medical marijuana program in the state of Ohio is administered through 3 executive branch departments. The first is the Department of Commerce, and they actually have had the heavy lifting. The Department of Commerce get to regulate the cultivators and the producers. And that really is the heavy lift of what they're having to do in the regulatory world. They also regulate the testing companies that test the product, that look at the concentration of THC and CBD, and make sure that what you're getting is actually what's in the products being sold. The Board of Pharmacy regulates the dispensaries, and the Medical Board regulates the physician recommenders. This is the website for the medical marijuana program. There's a lot of great information on that. So, you guys want to recommend medical marijuana? You've had 2 great talks. You think it's going to be fantastic. You want to use it for your patients. How do you do it? Well, you have to get an endorsement on your medical license by the medical board. You have to do 2 hours of medical marijuana related CME, and you can actually get links to where you can do that from the Ohio State Medical Association. It's on their website. So you do 2 hours of CME, then you go onto the medical board site, and then you can do this all electronically and request an endorsement, and they look at those every meeting, so once a month. It's probably higher than this now, but the last number I saw was pushing 300 physicians in the state of Ohio already have their physician recommender endorsements. So now you've got the endorsement on your license, you can do it. How do you do it? Well, what happens is the patient comes into your office. There is going to be a web-based program. The physician or the physician's designate has to enroll the patient personally in the facility into the web-based application. And then you, as the physician recommender, go into the web-based application and you recommend marijuana. And then they go to the dispensary, and it's already in the electronic system. The dispensary then accesses that, and it's connected without anything physical. It's all electronic. One legal note Since this is a Schedule 1 drug, and if you have a DEA license, you do not want to run afoul of the DEA, you cannot prescribe Schedule 1 drugs. You can recommend them. And so all of this is recommendation. And so there have been some folks who get skittish who go, I'm just going to recommend it because if you start putting things like dose, strain, whatever, it might be interpreted as a prescription. That's where we are legally. It is only approved for 21 conditions. When you see the patient, you need to document that you physically saw them. It cannot be over the telephone. You have to physically see them and perform a physical exam. You've got to document that. You've got to document the diagnosis, and it can't just be you say it. You've got to get documentation that that's what they have. And you also have to show that if there is a FDA-approved treatment for this, that they either have tried it and it doesn't work, or that they can't use it for some reason. So you have to document all of those steps to make sure that you're in compliance with the statute. And these are the 21 indications. There is a process through the state medical board that if you want to petition for another diagnosis, you can do that. And I think they're going to open that up November, December-ish. But currently, as of right now, these are the only conditions that you can legally write for in the state of Ohio. But it's pretty broad. And they're my citations, and you'll get all those in it.
Thank you, Dr. Mitchell. Obviously getting a lot of information. With that, we'll finish up with Dr. Harrison Weed, who has degrees from both MIT and Boston University. Since 1990, he's been with Ohio State in the Division of General and Internal Medicine, and for the last 20 years has served as the chair of the Pharmacy and Therapeutics Committee for the OSU healthcare system. Dr. Weed is going to talk about the potential adverse events. Dr. Weed. You knew that was coming. That's just too easy. It's too easy.
So you guys have had two real experts, people who know something, people who do research, both of whom serve on the governor's board. I get somebody whose name just happens to be Weed. It's been around a long time. It's been used as a medicine for a long time, literally thousands of years. But it's complicated. Like any medicine, as exemplified by the recent controversy, if you will, over the 81 milligrams of aspirin a day. If it can help you, it can hurt you. And I thought this was a particularly poignant way to describe it. To the agriculturist, cannabis is a fiber crop. To the physician of a century ago, it was a valuable medicine. To the physician of today, and even today, even though that was 69, it is an enigma. To the user, euphoric. To the police of medicine, to the trafficker, is a source of profit. To the convict or parolee, a source of sorrow. And we have people who are still locked away for marijuana. So let's talk first about what your patients think. This was a survey that was recently published, a survey of over 15,000 adults in the U.S., done in 2017. Half of them responded, published in the Annals. 81%, 4 of 5, thought that marijuana has at least one benefit. 2/3 thought it was in pain management. The idea of epilepsy and spasticity and multiple sclerosis are out there. Anxiety, stress, and depression, even though current evidence of the benefit of depression is quite small, if existent at all. And 1/3 agree to the statement that smoking marijuana helps to prevent health problems. 9 out of 10 think there are some risks. Most of them think it's a legal risk, but also they recognize that they have friends who've been smoking and keep smoking even though it's not doing them any good. And they understand that your brain doesn't work quite as well when you're smoking dope. 20% believe that secondhand marijuana smoke is safe for adults, and 5 to 10% believe it's also safe for children and during pregnancy. So that's what your patients think. 1 out of 5 think that marijuana is not addictive. How about children? So this is 20,000 children in grades 6 through 12. A quarter reported ever vaping. And 1/3 of those reported ever vaping cannabis. So 10% of middle school and high school students have vaped cannabis. if it's interacting on all the higher centers of your brain in some way, and your brain is developing, one has to wonder what's that doing to developing brains. And of course, it comes in a form that's perfectly delectable for children. So let me just read through this. Studies of THC specifically have focused on non-pregnant adult subjects, so there's few reports on what happens in pregnancy. The data from preclinical species, so we're talking your mice, your rats, show that THC readily crosses the placenta. And although fetal exposure appears lower than maternal exposures, the neurodevelopmental data suggests that prenatal exposure may lead to subtle, persistent changes in targeted aspects of higher level cognition, psychological well-being. Again, we're left with the final statement is, we don't know. We don't have the studies. We haven't done the work to really understand what are the potential adverse effects. Interesting study in mice. And they have a whole bunch of different things you can do with mice. Dr. Wenk showed us the mice swimming and finding a hidden platform to get on. They can do it quicker if they're old mice, and they get a little THC. When you take young mice that are in the adolescent phase of growing up and you expose them to a lot of THC, they're not as good at interacting with other mice. They're not as good at solving cognitive problems. However, at the same time, if you expose them to a combination of THC and CBD, you don't seem to see that adverse effect. So because there's a limit in data, to some extent, it's like that old thing from the accountant when he was asked by the head of the company, what's 1 + 1? And he closed the window and said, what do you need it to be? You can look for some data to support what it is you're wanting. How about breastfeeding? Current data looks like you're going to see about 0.8% of the dose that the mother's receiving. So it does get into breast milk, not at high concentrations. What does that mean? At this point, we don't know. So there are no human data to corroborate these observations. There is a lot of concern. This guy, Mandelbaum, wrote a paper a year ago, really trying to point out all the adverse effects. And his ultimate point was there's strong evidence that cannabis causes cognitive impairment and damages the brain, particularly in white matter, where the cannabinoid 1 receptors abound. And so he was, in essence, putting out a clarion call that we need to do more. A literature review of the association of cannabis with psychosis. So they looked through 5,000 references, they found 35 studies. They're all population-based, case control, so it's something. I had a buddy in med school who said, if you have to do statistical analysis, you did the wrong experiments. You should be able to see the difference, and then maybe do some statistics to analyze the effect. If you have to do a lot of statistical analysis, you need to have it with a certain grain of salt. They associated every use of cannabis with psychosis in a pooled adjusted ratio, 1.5 times. Frequent use of cannabis was double. So it appeared to be that the more you used cannabis, the greater the association. But was that a predilection for using cannabis because your brain was already desiring it, or was that a change to your brain? This can't answer that question. So this was a retrospective cohort study of 50,000 Swedish conscripts. They looked at self-reported use. Again, how good is that data? And the cannabis use was associated with an increased risk of developing a psychotic type presentation, which they called schizophrenia. And they saw some dose dependence. So if you ever used it, they say it was 1.2. If you used it with no other drugs, 1.3. If you used cannabis more than 50 times with no other drugs, then it was even more, 6.7. And they had similar results when they restricted the subjects who developed psychotic presentation more than 5 years after they were conscripted into the Swedish army. So someone took a small group of people and looked at changes to the corpus callosum. And people with schizophrenia have a corpus callosum that's not, they call it fractional anisotropy when you look at MRI. So it's something different about the myelination of the nerves. And the question was, how does this compare with a healthy control group, schizophrenic patients who don't smoke dope, and those who used it at a young age or those who used it at an older age? The cannabis-naive schizophrenic patients showed reduced fractional anisotropy, that is abnormal myelination. However, cannabis-using patients showed greater reduction, and the extent did not vary depending upon the age at which they started. So the conclusion was schizophrenia was not triggered more frequently by adolescents compared with later onset cannabis use, and the characteristic white matter abnormalities in the corpus callosum wasn't correlated with the age at which you started. Therefore, maybe it's two different things. There's changes that happen with the cannabis use, there's changes that happen with schizophrenia, but they're not, one isn't causing the other. They're two different things. What happens when people use cannabis? Sedation, dizziness, numbness, brain doesn't work as well, slowed reaction time, sensory disturbances. And if you get enough of it, of course, you get anxiety, nightmares, and it can even cause psychosis. So the data in Colorado showed that the legalization doubled the number of people who showed up in emergency rooms with acute cannabis toxicity. And they showed a threefold increase in the presentation of children with psychosis, whether it was specified due to cannabis or not. Again, the kids getting into the candies and the brownies, I think. Again, that's just an association. What happens to your heart and brain? You know, you can get low blood pressure, you get high blood pressure, you can get rapid heartbeat, and you can feel those rapid heartbeats. It tends to dry out the mouth. It can calm nausea, but can also cause nausea. And there's a hyperemesis syndrome. When you're used to doing a lot of dope every day and then you suddenly stop, there's that strange syndrome where you just feel nauseated. If you take a hot shower, it gets better. I don't quite understand why that happens. And the only treatment is you can get more cannabis, or you can just do none, and then eventually it goes away. And then there's a question about, in the long term, because there's all those receptors on the immune system, are you causing an immune suppression? And there's that question about decreased fertility. But again, controlled trials in people, the data's not there. The acute toxicity, of course, is just a furthering of the same effects, where you can feel so badly that you present with seeing things and hearing things that aren't there, psychosis, just being so doped out that you're sedated. So I used to prescribe it. I'm board certified in infectious diseases. I worked in HIV clinic for many years. And back before we had really effective drugs, I had people who were wasting away. And I tried it along with the other treatments to try to help stimulate appetite. And I had two types of responses. There were people who used marijuana a lot, and they could usually manage it. But most people didn't like the side effects. They said, it's okay, but I just don't like the way it makes me feel. So even though I tried to use the dronabinol, I often didn't have the uptake, and we'd have people kind of pop into things and taking out a little bit of the stuff inside to control their dose. The problem with the pharmacokinetics is when you eat it, it takes an hour, maybe even 4 hours before it hits you. And so nothing's happening, nothing happening, bang, I'm out. Or I'm seeing stuff and hearing stuff that isn't there. They say some sort of cannabis use disorder. I mean, this is a broad estimate, and it's a pretty unreliable estimate. 10 to 30% of people who use cannabis develop some sense of use disorder. That means they're using it in a way that it's not really helping them to live a better life. They're screwed up from their work or whatever. These are the things that are required for diagnosing a cannabis use disorder. And we know the withdrawal, anxiety, depression, can't sleep, irritability, not being able to eat. The Canadians have been dealing with this for a while. They've had medical marijuana longer than we have. And just last week, they have, across the country, legalized recreational marijuana. And this is what's proposed in the Canadian Journal of Anesthesia a couple of years ago. These should be contraindications. These should be cautions, things that make sense. Where's the data to back all that up? Oh, we don't have that. Sorry. There is an increase also in motor vehicle accidents. And there's a statistical association with more severe motor vehicle accidents. So one thing you could say, again, this is recommended by the College of Family Physicians of Canada website, is after you inhaled it, probably shouldn't drive for 4 hours. After you ate it, 6 hours. And if you actually felt it, if you got a little high, maybe you ought to wait more like $8. What can be used for, I think we already heard about that. Again, the Family Physicians of Canada website, I think, is an excellent resource for someone who wants to use it. I like this slide. It also comes from the Canadian Family Physicians because it compares the treatment of neuropathic pain. And you can see the little green guys are improved. The yellow guys are improved with placebo. So the placebo effect, and they're giving a placebo effect of 25%, which is modest. I mean, there are some studies where placebo effects can be as much as 50%. And then the not improved are the red guys. And you can see amitriptyline, high-dose opioids, venlafaxine, pregabalin, gabapentin, duloxetine. Cannabinoids are way down here. But don't forget that placebo effect. I think there's two reasons why people find it, use it, and they say it works for them, and I believe it works for them. Because you can marshal that placebo effect, and you can titrate the dose. You can titrate it, and you can get an effect within minutes if you're inhaling it. And you believe it's going to work for you, you're going to marshal that whole placebo effect, and maybe it's even more than 25%. So does it work? Yeah, I bet it does. What it counts for, if you do a double-blind placebo randomized controlled trial, it's probably not going to be that good. But if you give the patient control, and if they believe in it, I bet it's pretty good. We have FDA-approved cannabinoids, as we talked about. You know, there are benefits that are FDA-approved. There's the adverse effects that you always have to work with. And we currently have a lot of other agents that are usually more effective in patients. There's thoughts about when you should stop giving it to somebody. And again, these kind of make sense. They're the same kinds of things that we would use with other Schedule II medications, with opioids. Thank you very much.
Well, thank you to all of our presenters for some really outstanding presentations. What we'll do is we'll just have you sit right here since it's most convenient, and we'll open it up to questions.